and we will discuss a bit about indices of weaning and if they are useful or not. No conflict of interest, as usual, from my side. So I'm referring to a quite recent study showing that, as argued before by Laurent, that reintubation is associated with higher mortality. This is a list of studies with different rates of extubation failure. And the mortality in reintubated patients, as you can see here, is quite high, up to 70%, as compared to patients who are not reintubated. So this means that we should try to avoid as much as possible reintubation, and we will discuss if weaning indices can help in this setting. So first of all, we have to remind that we have to consider the clinical condition of the patients. First of all, the resolution of improvement of the condition that led to mechanical ventilation initiation. The patient has no hypersecretion, for example, defined as the need for aspiration more than 2 per hour. Effective cough, quite reasonable level of hemoglobin, adequate oxygenation, PO2-FO2 at least higher than 150, control of body temperature, no dependence from sedative or vasopressor agents, and no acidosis of electrolyte disturbances. I think this is the first point to take into account, apart from any indices or whatever else. And as Laurent showed, many physicians, they can extubate even without different protocols, and of course, adequate balance. So there are different indices for weaning, as reported here in a recent paper, and they are very, very attractive, as you can see. And the most common is the rapid shallow breathing index. So the rapid shallow breathing index, as you know, is the ratio between respiratory rate and tidal volume. Usually when it's less than 110, this is considered a good sign. It's the most well-known and used during spontaneous breathing trial, and I summarize here the AUC curve, so the sensitivity and sensibility of this ratio, which is between 0.7 to 89. It's not bad, but it is not a magic number. Then it can be used in T-tube or CPAP PSV, and the thresholds are different. So the famous 110, 105 apply to spontaneous breathing, but do not apply to CPAP or PSV, where we have much different numbers. It's often used in conjunction with SBT to determine if it should be continued. But more importantly, there is even some evidence that it can be even delay ventricular discontinuation. And just report this nice randomized trial. There are not many in this field. I think we have to think in the next future. Quite nice, a reasonable number of patients. Some patients according to the SBT, the rapid shallow breathing index, and other patients in a conventional way. So look at that. The patients in which rapid shallow index was not used, they have a weaning time of 2 days. It was even longer in patients where we continue to collect numbers, okay? And this was even significant. So this is an interesting study, very provocative. We like indices, but sometimes they can be even worse. Then respiratory rate, you see the OC is low and very wide range, 0.5, I remember, means that it's just flip a coin. The tidal volume, even there, 0.67, 0.81. Minute ventilation is another parameter that can be considered, as well as PO2-FO2. What about this very clinical index? This is a study showing that, for example, oxygenation or even CO2, you see, the OC curve is very poor. So this PO2-FO2 less than 150 or higher than 150 is considered in all studies, in all tables, and when you look specifically, it is just a little bit better than to flip a coin. The maximum inspiratory pressure, which is considered around 15 to be effective, is very widely used. You see, the AOC is a little bit more than flip a coin. So we use indexes sometimes, if we use them, that are very poor. Different methods and ranges. Of course, extreme weakness suggests failure. However, so I mean, this can be if the number is extremely low. The PO1, again, look at the wide range of the AOC curve, even less than to flip a coin, and correlates with the central drive. So it may be absolutely inaccurate in presence of muscular weakness. Then you have more complicated indices like PO1, standardized for Pmax or rapid shallow breathing. And if you look at the maximum inspiratory effort, now there are some even different devices that can be applied. This is one of them, that you can occlude the airways even during mechanical ventilation, and the patients start to inspire, and you see the increase in the inspiratory effort of the patient. And usually, these parameters should be evaluated after at least 30 or 40 seconds. Then there are even more complex indices. This is the CROP index. There are very few studies, a bit complicated, you see, with dynamic compliance, respiratory rate, oxygenation, maximum inspiratory pressure, and including dynamic compliance and PO2 respiratory rate. The core index, again, is a mixture of parameters that have been proposed, as you can see there. And however, if you look here, the PO2, the CROP, the respiratory rate, tidal volume, maximum inspiratory pressure, it's just like to flip a coin. You see the sensitivity and specificity. And these are simple to wean patients, as defined before. And even if you look at difficult to wean patients, we have data, as you see, different parameters that I mentioned you before, that the sensitivity and specificity is very low, and the accuracy is very low. It's a little bit more than flip a coin. Even more complicated indexes we use, no better information we get. More recently, very interesting parameters has been proposed is the integrative weaning index by my friends in Brazil, which is considered as a limit at 25. It's composed by compliance, saturation, and rapid shallow breathing. And these parameters has been shown. There are not many studies with this is a comparison with the tidal volume at 0.8 as an OC, the compliance alone, the rapid shallow breathing, all in this study around 80, while this index showed, at least in this particular study, a very good AOC curve. You see here, of course, has to be reproduced in other study. And was particularly useful to detect those patients who passed the SBT but needed reintubation afterwards. So it was a nice parameter to predict the reintubation at a bit later in the, after extubation. And there are recent data also suggesting, as you can see here, that these parameters might be extremely helpful even in elderly patients. So it's a parameters that we can consider. And as you see, this parameter integrate the compliance. And this is a study that shows that compliance per se is a very interesting parameter for prediction of weaning. As you can see, it's around LC curve 86, which was even better than most of the other parameters that I showed you before. So compliance is something that we have to take in account. And how can we measure compliance in a patient during assisted ventilation? In controlled ventilation, it's very easy. You hold the inspiratory button. But in assisted ventilation, this is a study that we did many years ago with my friend and colleague, Giuseppe Foti, when I was working in Monza. And you see one patient on the right in pressure support, and then we have inspiratory hold. And if the pressure support is high enough to unload the respiratory muscle, more or less the pressure at end inspiration is equivalent to the level of pressure support. And this is sort of the plateau pressure during assisted ventilation. And the driving pressure is the difference between the plateau pressure and the end expiratory pressure. On the other side, you see another patient in which when we occlude the airways, the plateau pressure, so the pressure of relaxation during assisted ventilation, increases, is higher than the pressure, the higher pressure during inspiratory, during pressure support. What does it mean? That the difference between the pressure support level that we set and the plateau pressure at occlusion is the activation of the respiratory muscles at the end of inspiration. So higher is this difference, higher is the activation of the respiratory pressure. But for what is important for us actually is that again we can measure a sort of compliance of the respiratory system. Of course, we need a patient that is not a very, very high drive. But this just to show you that it's possible to measure the respiratory compliance even during assisted ventilation. And we are not very used to do that routinely at the bedside. And I show you that this can be integrated in a very interesting indices for weaning. Another possibility is to use echo. Echo is becoming very popular in the ICU. We introduced many years ago in our unit, and now everyone is using echo, sometimes too much. So we look at the echo and we don't look at the patient. But echo is very useful. And this is an example, for example, when you see the displacement of the diaphragm. You see on the right, this can be taken here on the subcostal line. And the other parameter is the thickness. You see the two slices of the diaphragm, narrow or bigger. Why? Because we are contracting the diaphragm. And this is taken with a linear probe here on the lateral part of the chest. So you need two probes. I don't want to enter into detail, but it's relatively easy to do. And this is a very recent meta-analysis showing that the diaphragm thickness is the most important in terms of prediction for weaning outcome. You see the OC is very high, around 90%. The thickness, so with the linear probe on the lateral chest. The diaphragm excursion that you can take with the curvilinear probe, subcostal, is a little bit less, as well as the lung ultrasound score. So the thickness is very interesting. We have not to forget, however, the hemodynamics. This will be discussed by Professor Pinsky afterwards, but this is just because I like the title, echocardiography, a help in the weaning pressure. We have to remind that it is not only a question of the respiratory muscles, but also, and likely even more than we think, the heart. And Professor Pinsky for sure will address this issue. But the heart for me is very important, not only for weaning, also for other reasons. Then there are a little bit more complicated systems. This is, for example, is the comparison between rapid shallow breathing and the use of electromyographic activity of the diaphragm. Again, here does not seem to give us major additional information. Then there are other more complicated, but this is for the future, is the variability. You see here in a TP's trial success, you have a lot of variability in peak inspiratory flow, tidal volume, and rapid shallow breathing. This is not the case when we have a TP's failure. You see the breathing pattern is much more flat, much less variable. Variability probably makes a difference also in the weaning evaluation, and this is not considered in the usual parameters. And also the trends, this is a bit complicated study, but you see here that the difference in success failure is followed in the trends of the different parameters, respiratory rate, heart rate, and SpO2. We are used to analyze one single parameter at one time shot. while another opportunity is to look at the trend of the variables in the evaluation of possible new indices. And then a very complex area, but I think is very exciting for the future, is the prediction by Urine's artificial neural network. And there are some data, as you see here, combining different score or the artificial neural network that seems to have some possible advantages in the next future. Now we are applying the neural network model, for example, to predict postoperative pulmonary complications. So, and in many other areas of the field. So, to conclude about the question that was asked to me today, indices of weaning, are they useful? We know that we have several observational investigations that examine the accuracy of the weaning prediction. So we have some data. However, I have the feeling that there are no high-level evidence that demonstrate that routine application of these weaning parameters may improve the clinical management of our patients. That indices of weaning can be useful when the decision to wean from mechanical ventilation perhaps is very problematic, even in presence of favorable clinical screening criteria. We have always to remind that the cardiac function is very important, and so the ultrasound, as well as we have now some information, and especially the thickness, the changing thickness of the diaphragm, may have a role in the next future in the evaluation of weaning procedure. And I also think that we have future perspective, so the use of dynamic data, the variability patterns, and the use of artificial networks to improve our knowledge about the indices to predict weaning in our patients. Thank you so much.
Thank you, Paolo. The paper is open for discussion. Questions from the audience?
No.
Laurent Brochard.
Yeah, thank you, Paolo. I may have a slightly different vision of that. I think we should ask the question differently. And we should ask the question, why do we need indexes? So what is the clinical question? And for the simple weaning group, which I mentioned, the question is how soon can we detect that a patient may be submitted to a screening trial? In this regard, if you test a patient at a stage where you have no idea, for instance, the F/VT is a fantastic tool, very simple, 2 minutes, very useful to detect patients who can be submitted to a spontaneous breathing trial. But that's a very different question than using this index when 85% of the patients will be successful, like in the randomized trial we've showed, has no chance to improve the prediction. In patients who have failed the first attempt or maybe the second, the third, you need something different. Maybe it could be to understand what's wrong with the weaning of this patient, or it could be to have an aid for decision for extubation. So that's all very different question. And again, these studies just looking at the predictors in different group of population of weaning without better identify the subgroups, I think it's useless, and it may be detrimental because we may remove some very good indexes for specific questions.
Absolutely, I agree with you. In fact, I think that if this approach in terms of use of these indexes in these terms can be even worsening the procedure in this patient, as shown in the study that I show you. I think that can perhaps have some help and support in those patients in which we can have some even more doubts, but not in the early phase, but eventually in the later phase. And I agree with you that eventually there can be some differences in different population of patients, but there are not clear data on that.
Michael Pinsky.
But the trends, I think that one of the future is the trends, because then to try to not avoid that once that we have extubated even a patient, then we can have a look if the patient is going to deteriorate further.
Michael.
Well, first of all, wonderful review of all the failures of the weaning parameters. And the ones that started to look good, and this is going to underscore what I'm going to say, but I'm not going to talk about your parameters, are ones that look at work of breathing. Respiratory compliance is a measure of the load of the respiratory system, and you showed that was good. And then you looked at the artificial neuronet. What that looks at is heart rate variability and other evidence of cardiovascular stress. And it's very interesting to see that methods that measure once the load of the work of breathing and the cardiovascular stress are the ones that you pulled out at the end, which were the best parameters. And I wanted to underscore that point.
Yeah, I think that this is the view in which we should focus at least part of the research in this area.
Thank you very much, Paolo.